Picture this. You've just had an incredibly long day. You finally turned off the TV, your phone is on the charger, and you're just settling into bed.
Oh, it's the best part of the day.
Right, exactly. You're completely ready for sleep. The room is dark. The house is, it's completely quiet. And then out of absolutely nowhere, you hear it.
Yep.
A high-pitched ringing. Or, I don't know, maybe it's a buzzing, or a low hiss, or even this weird rhythmic ticking sound. And it's right there in your ear.
Or sometimes it feels like it's right in the center of your head, yeah.
Right. So you sit up, you look around the room, you're trying to figure out if, like, an appliance was left on or if there's something going on outside your window.
But then the reality sort of, slowly sinks in.
Yeah, the room is totally silent. The sound is coming from inside you. It's this universal, incredibly relatable, and honestly, sometimes genuinely terrifying scenario.
It really is. It's a phenomenal way to frame it because that exact moment, that sudden realization that the sound is internal, is basically the defining psychological experience of tinnitus.
And millions of people experience this, Yet for something so common, it's just profoundly misunderstood.
Absolutely. And you're so right about how isolating it can be.
Yeah.
Because when you're the only one in the room who can hear a blaring siren or, a constant hum, it feels less like a medical condition and more like a glitch in your reality.
Oh, 100%. It's like a glitch.
The quietest moments of your day suddenly become the loudest. And that is a profound paradox that millions and millions of people worldwide struggle to navigate literally every single day.
And I imagine the cognitive load of constantly processing a sound that just shouldn't be there, that's got to be exhausting.
Oh, it's incredibly exhausting.
And that is exactly why we're doing this deep dive today. We're pulling our insights from Gary Brecka's Ultimate Human podcast, specifically looking at a truly illuminating segment dedicated entirely to tinnitus.
It's a fantastic source.
It really is, but we're taking a completely different angle than what you might normally hear during, like, a standard 5-minute medical visit.
Yeah.
Our mission today is to completely shift the focus.
Right, getting away from just the ear itself.
Exactly. We're going to move away from just looking at the physical, mechanical anatomy of the ear, and we're going to dive really deep into the neural circuitry of the brain.
Which is where the real mystery is.
Right. We want to uncover the surprising science behind why these sounds happen at a cellular level, explore some genuinely cutting-edge neurotreatments, and also, look at the immediate daily fixes you can use right now.
Yeah, actionable stuff.
Exactly. Okay, let's unpack this, because tinnitus is not just an annoying symptom. It's a literal window into the complex workings of our auditory system, and by extension, the brain itself.
I love that. That phrase, a window into the complex workings, is exactly the right starting point for this.
Oh, good.
Because we tend to think of hearing as this very simple, mechanical process.
Yeah.
Largely because that's how it's taught in grade school, right?
Yeah, like sound waves hit the eardrum, the little bones vibrate, signal goes to the brain, and boom, we hear a noise.
Exactly. It feels like this linear, straightforward transaction. But tinnitus forces us to acknowledge that the system is infinitely more complex, highly dynamic, and frankly, a lot more fragile than we realize.
It's way more delicate.
It really is. It's a systemic issue, a neurological issue, and a physiological issue, all just wrapped into one persistent sound.
Which brings us to, I guess, the ultimate guiding question for our entire deep dive today.
Okay, let's hear it.
If the sound you're hearing does not actually exist in the outside world, if there's no physical vibration in the air causing it, where exactly is it being created inside of you? And more importantly, how on earth can we turn the volume down?
Well, to answer that, we really have to start by tearing down our basic assumptions about what a sound actually is.
Okay.
When we talk about tinnitus, we're broadly defining a phenomenon where a person hears a sound ringing, buzzing, hissing that has absolutely no external source.
Right. Nothing in the room is making that noise.
Exactly. But the medical field actually breaks this down into two very distinct categories. And this distinction is the absolute bedrock of understanding how to approach and treat it.
Okay, what are the categories?
We have subjective tinnitus and we have objective tinnitus.
I really want to spend some serious time here because this was a major paradigm shift for me when I was looking at the research.
Oh, but it's for a lot of people.
Yeah, because I always just assumed tinnitus was tinnitus. Like a ringing ear is a ringing ear, right?
Right, that's the common assumption.
But most tinnitus falls into the subjective category, meaning it's rooted deeply within the auditory system itself. It's a true phantom signal, meaning you're the only person on the planet who can hear it.
Exactly. Subjective tinnitus is the classic presentation. It accounts for the vast majority of cases.
Okay.
It's the phantom signal that exists entirely within the confines of your own sensory processing. So the hardware of the ear, or the software of the brain, is generating a signal that translates into sound, but there's no physical acoustic vibration anywhere in your body.
So it's totally made up.
Yeah, it's entirely subjective to the individual experiencing it. It's basically a sensory hallucination.
But then, and this is the part that blew my mind, we get to objective tinnitus, and this is where my assumptions just completely fell apart.
Right, because it's not a hallucination at all.
Exactly. We're talking about physical phenomena, specifically vascular anomalies or muscular contractions. Wait, let me make sure I'm getting this right. You're telling me that in some cases, the ear is literally acting like a stethoscope, listening to the body's own internal plumbing or twitching muscles.
Yes. What's fascinating here is that your stethoscope analogy is scientifically spot on.
That is wild.
In the case of objective tinnitus, the sound actually does exist. It's not a phantom signal generated by a confused brain. It is a real, physical, acoustic sound being created inside your body.
Like right next to the ear.
Yeah, usually very close to the delicate structures of the middle or inner ear.
Wait, so if a doctor were to somehow put like a highly sensitive microscopic microphone inside your ear canal, they could actually record the sound and play it back.
In many cases of objective tinnitus, yeah, absolutely.
Are you serious?
I am. In fact, doctors will often use a specialized stethoscope placed on the skull or right near the ear just to listen for it.
That is incredible. So what's
Yeah.
actually making the noise?
Well, when we talk about vascular anomalies, we're talking about fluid dynamics.
Mm-hmm.
Our bodies were essentially these complex networks of biological plumbing, right?
Right.
Blood is constantly rushing through arteries and veins, particularly the major vessels that run right next to the auditory structures, like the carotid artery and the jugular vein.
Okay, that makes sense.
Usually this blood flow is perfectly laminar, meaning it's smooth, streamlined, and completely silent.
Right, like a deep river flowing really slowly.
Exactly. Great image. But if there's an anomaly, like perhaps a blood vessel near the ear has developed a stricture, or plaque buildup has narrowed the passage, or there's a change in the blood flow dynamics due to high blood pressure, that laminar flow becomes turbulent.
Ah, so it gets rough.
Yes. Think of that smooth flowing river suddenly being forced through a narrow, jagged canyon. The water churns and it creates noise.
And the ear just hears that churning.
Precisely. Because the bones of the skull are excellent conductors of sound and the ear is just exquisitely sensitive to vibration, it simply picks up the acoustic noise of that turbulent blood flow.
So the person is literally hearing the rushing of their own blood.
Yeah.
And because their heart is pumping it, it translates as a whooshing or rhythmic ticking sound that perfectly matches their pulse.
Precisely. We call that pulsatile tinnitus.
Wow.
And the same mechanical logic applies to the muscular contractions. There are tiny muscles in the middle ear, the tensor tympani and the stapedius. Their normal job is to contract in response to loud noises, to dampen the vibration of the ear bones, to protect the inner ear. But occasionally, these muscles can develop a myoclonus.
Oh, what?
A myoclonus. They start to spasm or twitch involuntarily, just like an annoying eyelid twitch you might get when you haven't slept enough.
Oh, I hate those. And because those tiny muscles are physically attached to the bones of the ear picks up the mechanical vibration of the muscle twitching.
Yes, exactly. It's a physical acoustic sound generated locally by a spasming muscle and picked up by the biological microphone of the inner ear.
What does that sound like to the person?
It often sounds like a rapid clicking or a fluttering noise, almost like a moth trapped inside the ear canal.
Oh, that sounds awful. But that distinction is absolutely critical, right? Like if you have a patient who's hearing a ticking sound and the doctor just assumes it's the standard phantom ringing of subjective tinnitus, they might completely miss the fact that it's actually a measurable vascular issue or high blood pressure or a muscle spasm.
And that misdiagnosis is exactly where a lot of patient frustration begins.
I can imagine.
Because if the root cause is a vascular anomaly or a spasming muscle, trying to rewire the brain's auditory processing or, prescribing sound therapy, it's just going to fail completely.
Because you're treating the wrong thing.
Exactly. You have to address the actual source. You have to fix the plumbing, manage the blood pressure, or relax the muscle. The treatment pathway for objective tinnitus is entirely mechanical and physical.
But of course, that's only a small percentage of cases, right? The vast majority of people are dealing with subjective tinnitus,
Right, the phantom sound.
which perfectly sets up our next exploration. Because understanding how we hear the sound naturally leads us to ask what triggered the system to malfunction in the first place.
Exactly.
If we're looking primarily at subjective tinnitus, that phantom signal that most people experience, what is actually causing the biological hardware to misfire?
Well, the underlying triggers for subjective tinnitus are incredibly diverse. We're looking at a pretty wide array of catalysts here. Damage to the inner ear cells, ototoxic medications, infections, cardiovascular disease, and neurological disorders.
Okay, let's really slow down and look at that list because it is wild.
It's a lot,
We're
yeah.
talking about wildly different things, from a viral infection to a pharmaceutical pill you swallow to the systemic health of your heart. How can things that are so completely unrelated functionally all result in the exact same annoying buzzing sound in the ear?
It all comes down to the concept of the auditory pathways. Think of the auditory pathway as this highly complex, exquisitely calibrated fiber optic network.
Right, a fiber optic network.
Right. It starts at the outer ear, travels through the mechanical amplifier of the middle ear, enters the fluid-filled cochlea of the inner ear, where physical vibration is converted into electrical impulses, runs along the auditory nerve, and finally arrives at the complex processing centers deep within the brain cortex.
Wow, so it's an entire chain of command. It's not just one component that can fail.
Exactly. And because it's a long, highly specialized chain, there are multiple points of vulnerability.
Mm,
Let's take the most common trigger, damage to the inner ear cells.
right, like from loud noises.
Yeah. Inside the cochlea, there are thousands
Wow.
of microscopic hair cells. And these aren't hair like on your head. They're delicate sensory receptors called stereocilia. They sway in response to the fluid waves created by sound.
Like kelp swaying in the ocean current.
That is a great visual, yes.
Yeah.
And as they sway, they open tiny ion channels that trigger an electrical signal. This is called mechanotransduction.
Mechanotransduction. Got it.
But these stereocilia are incredibly fragile. If you're exposed to a sudden, massive acoustic trauma like a gunshot or a firecracker, or even chronic loud noise over time, like working in a factory or blasting headphones, the sheer mechanical force of the sound waves can literally shear off, permanently bend these stereocilia.
They just get flattened.
Yes,
And unlike a blade of grass that springs back up after you step on it, they do not recover, right?
unfortunately, no. In humans, once those hair cells are dead, they do not regenerate. Man. So you have a physical break in the circuitry. They stop sending the correct electrical signals down the fiber optic cable, which, as we'll discuss in a moment, causes the central nervous system to basically panic.
Okay, so physical trauma to the starting point of the highway. That makes logical sense. But let's look at ototoxic medications.
Yes.
We're talking about drugs that inadvertently poison the delicate hair cells as collateral damage. It really highlights a sobering reality of pharmacology. You take a medication to clear up a severe infection, and as a side effect, you damage your hearing.
It's a profound example of how interconnected our biology is. We often treat the body like a series of isolated compartments, but it's a single, continuous ecosystem.
So what kinds of drugs are we talking about here?
There are over 200 known ototoxic medications. We're talking about certain classes of powerful intravenous antibiotics like aminoglycosides, certain chemotherapy drugs used to fight cancer, and even high doses of common over-the-counter anti-inflammatory drugs.
Wait, really? How does a pill I swallow for inflammation end up damaging the stereocilia in my ear?
It happens at a biochemical level. These medications circulate in the bloodstream. Now, the inner ear has its own highly specialized fluid environment called the endolymph.
Okay.
To maintain the exact chemical balance required for those hair cells to fire, there's a complex barrier similar to the blood-brain barrier. But some of these ototoxic molecules were able to cross that barrier.
Oh, wow. So they get right in there.
Yeah. Once inside the inner ear fluid, they can disrupt the ion channels, cause oxidative stress, or literally trigger cellular apoptosis, which is programmed cell death in the hair cells. The medication wasn't targeted at the ear, but the biochemical makeup of the ear made it uniquely vulnerable to the drug's toxicity.
That is terrifying. Which brings us to another major trigger that feels completely disconnected at first glance. Cardiovascular disease.
Right.
Again, my heart is in my chest, my ears are on my head. How does a heart issue create a phantom ringing sound?
It traces back to the sheer metabolic demand of the auditory system. We discussed how blood flow can cause objective tinnitus, but poor blood flow is a massive driver of subjective tinnitus as well.
Okay, how so?
The inner ear requires a highly stable, continuous and robust supply of oxygen and glucose to function optimally. Those delicate hair cells and the structures that maintain the endolin fluid are incredibly demanding metabolically. They do not have their own stored energy reserves.
So they're basically living paycheck to paycheck, biologically speaking.
Exactly.
If the supply chain stops for even a second, they're in trouble.
Perfectly stated. And cardiovascular disease fundamentally compromises that supply chain. The blood vessels supplying the inner ear are microscopic. They're part of the microvasculature.
Really tiny.
Very tiny. So if a person has hypertension, that high pressure damages the delicate linings of these tiny vessels. If they have atherosclerosis, plaque buildup restricts the diameter of the vessels, limiting the flow of oxygenated blood.
So the inner ear cells are essentially suffocating.
Yes.
They're experiencing hypoxia. And their response to that metabolic stress is to misfire, sending corrupted signals down the auditory nerve.
Precisely. The hair cells are struggling to maintain their electrical resting potential because they just don't have enough cellular energy. This causes them to leak neurotransmitters erratically, sending a barrage of chaotic noise to the brain.
Wow.
And this is a critical takeaway for you, the listener. It's so easy to compartmentalize our health. We think of our hearing as completely separate from our treadmill routine or our diet.
Right. Totally separate boxes.
But there is a direct physiological line between the endothelial health of your cardiovascular system and the clarity of your auditory experience. Managing your systemic blood pressure might actually be the most effective thing you can do to protect your hearing over the long term.
That is a massive paradigm shift in how we view holistic health. And the final triggers we need to touch on are infections and neurological disorders, right?
Yes.
Like a viral infection, like a severe bout of COVID-19, or even just a really bad upper respiratory virus, can cause severe neuroinflammation along the auditory nerve itself.
Yeah, the virus itself, or the body's immune response to it, can inflame the 8th cranial nerve, which is the auditory nerve. Inflammation causes swelling, and swelling compresses the nerve fibers, disrupting the signal transmission.
Ah, okay.
So whether the mechanism of injury is a virus causing inflammation, a medication causing biochemical toxicity, a loud noise causing physical trauma, or cardiovascular disease causing metabolic starvation, the end result is the same.
The system breaks down.
Exactly. The peripheral auditory system is compromised, the input signal drops, and the individual experiences a persistent phantom sound.
Okay, so we've established that these triggers start in the body or in the physical ear itself. They are the initial spark.
Yeah.
But this is where the science takes a monumental pivot.
Oh, absolutely.
Because while the trigger might be in the ear, the actual sustained long-term experience of the sound, the reason it doesn't just go away after the ear heals happens somewhere much deeper.
Yes. And this is the frontier of modern audiology and neuroscience. We have to move past the physical anatomy of the ear and enter the realm of neuroplasticity and the central nervous system.
Let's get into this because this completely changes how we think about a cure. Recent studies linking noise-induced hearing loss to tinnitus explicitly state that it's not just about the ears, it's about physical changes in the brain's neural network.
Right.
The brain's structure and function are actually altering themselves.
If we connect this to the bigger picture, this is the exact moment our understanding of tinnitus evolves from a simple mechanical defect to a highly complex neurological adaptation.
Okay.
For decades, standard medicine focused almost entirely on the peripheral anatomy. If you complained of ringing, the doctor would examine the eardrum, test for physical hearing loss, and basically just look for a broken part inside the ear.
Right. And what happens when they look in there and say, well, your eardrum is fine and your hearing test is only showing a tiny bit of high-frequency loss, there's nothing we can do?
That has been the profoundly frustrating reality for millions of tinnitus sufferers. They're told there's no physical problem, yet the ringing is deafening.
So how do we explain that discrepancy?
The discrepancy is explained by looking at the brain. The inner ear might be the site of the initial damage. Perhaps a cluster of high-frequency hair cells died off. But the brain is where the tinnitus is actually generated and sustained.
So if the inner ear is damaged, it stops sending the correct signals to the brain. There's a drop in the data stream.
Exactly. It's a phenomenon known as afferent deprivation. The auditory cortex of the brain expects a constant baseline stream of electrical input from the ear. Even in a quiet room, there's spontaneous firing.
Just to keep things online.
Right. When those hair cells die, that input suddenly drops. But the brain is an incredibly active, dynamic, and frankly impatient organ. It absolutely despises a vacuum.
So it tries to fix the problem itself.
Yes. Through a process called neuroplasticity. When there's a loss of sensory input, the brain's neural networks attempt to compensate. In the auditory system, particularly in an area of the brainstem called the dorsal cochlear nucleus, the neurons recognize that they aren't receiving signals from the ear.
So what do they do?
They turn up their own internal sensitivity. This is known as the central gain theory.
I think of this like a computer monitor losing its signal from the hard drive.
Oh, that's interesting.
Yeah, like you unplug the HDMI cable and the monitor loses the data stream. But instead of just going completely black and accepting the silence, the monitor panics.
Right.
The internal software cranks up the brightness and starts generating its own internal test patterns, flashing colorful lines and producing static on the screen. The monitor is trying to display something, anything, because it is designed to process a signal.
That is a brilliant analogy. The auditory processing centers in your brain are that computer monitor. When the inner ear fails to send the expected signal, the brain's neural networks turn up their internal amplifier to try and catch the missing signal. But in doing so, they become hyper-excitable.
They go into overdrive.
Exactly. They start firing spontaneously and synchronously. That
Which completely explains why traditional treatments often hit a brick wall. You're treating the catalyst, but not the current reality of the disease.
Exactly.
The initial treatment might have been a loud concert 10 years ago. The ear healed as much as it could. But the reason the ringing persists today is because the brain learned a new hyperactive pattern, fortified those neural pathways through constant use, and locked it in. The tinnitus has centralized.
Precisely. And this operates on the basic neurobiological principle of neurons that fire together wire together.
Right, habit formation on a cellular level.
Yeah. The longer those auditory neurons fire in that hyperactive synchronized state, the stronger those pathological connections become. The brain gets really, really good at generating the tinnitus.
So if the brain's structure has changed to create this phantom sound, then it stands to reason that the next generation of treatments cannot just focus on the ear.
Not at all.
We have to go into the neural networks. We have to figure out how to rewire the mind.
And that leads us to the absolute frontier of modern neurological treatment.
Neuromodulation. Okay, here's where it gets really interesting. We're talking about utilizing technology to interact directly with the brain's electrical signals. We have transcranial magnetic stimulation, or TMS, and we have transcranial direct current stimulation, or TDCS.
To understand how these incredibly advanced therapies work, we have to refer back to the fact that the phantom sound is fundamentally an electrophysiological signal in the brain.
Right, it's electricity.
Yes, every thought you have, every emotion you feel, and every sound you perceive is driven by electricity. Neurons communicate by firing action potentials, tiny electrical impulses.
Okay.
When we say the brain has rewired itself to create tinnitus, we mean that a specific network of neurons in the auditory cortex has developed an abnormal, hyperactive electrical rhythm.
They're caught in a feedback loop, just constantly firing. So if the problem is abnormal electricity, the solution is to use external physics to correct that electrical misfire.
Exactly. The goal of both TMS and TDCS is to recalibrate the brain's response and restore normal baseline neuronal activity. We are bypassing the ear completely and going straight to the source of the static in the cortex.
Let's break down the physics of this, starting with transcranial magnetic stimulation. TMS. So transcranial means across or through the skull. So we're passing magnetic fields through the bone to interact with the brain tissue.
Correct. TMS utilizes Faraday's law of electromagnetic induction. A specialized electromagnetic coil, often shaped like a figure 8 to create a highly focal point, is placed against the patient's scalp.
Okay.
When a rapid high-intensity current is passed through that coil, it generates a powerful magnetic field.
And magnetic fields pass through the skull and cerebrospinal fluid without any resistance or pain, right?
Right, and here's the crucial part. When that rapidly changing magnetic field enters the conductive tissue of the brain, it induces a secondary electrical current directly within the neurons themselves.
Wait, so you're basically using a magnet on the outside to force an electrical reboot on the inside, like hitting a reset button on a malfunctioning circuit board.
That is exactly the mechanism. By applying specific targeted frequencies of magnetic pulses to the hyperactive auditory centers of the brain, scientists are attempting to induce something called long-term depression, or LTD, in those synapses.
Long-term depression, meaning they're trying to suppress the activity.
Yes, they're actively trying to train the hyperexcitable neurons to become less responsive, to stop firing so aggressively,
Yeah.
essentially turning down the volume of the electrophysiological signal over time.
That is so cool. And what about transcranial direct current stimulation, or TDCS? How does that differ mechanically?
Well, while TMS uses magnetic pulses to force a current, TDCS uses actual but extremely low-level direct electrical currents.
Actual electricity?
Yes, but very mild. Small sponge electrodes are placed on specific locations on the scalp, and a very mild current, usually just 1 or 2 milliamps, is passed between an anode and a cathode.
A current that small isn't going to shock you or, like, force a neuron to fire instantly, right?
No, the current is subthreshold. It doesn't force neurons to fire an action potential. Instead, it alters their resting membrane potential.
What does that mean in practice?
Depending on whether the current is flowing toward or away from the neurons, it makes the brain tissue either more excitable or less excitable. In the context of tinnitus, the goal is cathodal stimulation over the auditory cortex, applying a current that makes it harder for those hyperactive neurons to fire on their own. It acts as a neural dampener.
It is genuinely mind-blowing to imagine this becoming standard care. We're talking about a world where tinnitus is mitigated or even put into total remission by literally recalibrating the brain network.
It's an incredible prospect.
You just sit in a chair, a device delivers a targeted magnetic or electrical field to your cortex, and the phantom signal that has been tormenting you for years begins to fade because the neurons are finally learning to be quiet again.
It represents a monumental shift from just managing the psychological distress to potentially reversing the underlying neurological pathology.
Yeah.
We're trying to erase the neural blueprint that creates the illusion.
But I want to make a very important pivot here. Bridging the gap between this high-tech brain stimulation and our basic biology.
Okay, sure.
Because neuromodulation is incredible, but it relies on neuroplasticity. It relies on the brain physically breaking down old synapses and building new ones. You cannot ask the brain to fundamentally rewire its structural networks if the body does not have the raw biological materials required to build those new pathways.
This is a vital connection to make. Systemic health is the absolute prerequisite for targeted neurological recovery.
Right.
The biology of protein synthesis and cellular repair cannot be ignored if you want your brain to heal.
So let's explore the mechanics of this, specifically looking at amino acids and protein absorption, because there's a staggering inefficiency in how we usually approach tissue repair. When we think of building muscle or repairing tissue, we think of drinking massive whey protein shakes. But the biological reality of absorption is kind of shocking. Some standard protein sources can be as little as 20% bioavailable for actual tissue synthesis.
The difficulty lies in our body's nitrogen utilization. Proteins are complex molecules made of long chains of amino acids, which contain nitrogen. When you consume a complex protein like whey, your body has to expend a massive amount of digestive energy to break those long chains down into individual amino acids before it can absorb them into the bloodstream.
And if the body can't break them down efficiently, or if the amino acid profile isn't perfectly balanced for human synthesis, what happens to the rest of it?
That's where the 20% figure comes in. If only 20% is utilized for building new proteins, whether that's muscle tissue or the structural proteins required for neuroplasticity, the remaining 80% is converted into glucose for energy or processed by the kidneys as nitrogenous waste.
It's a massive biological inefficiency.
Yes, it is.
Which brings us to the concept of highly optimized essential amino acids. If you want to supply the construction site of the brain with the exact materials it needs to rewire the auditory cortex, you shouldn't be sending a pile of raw, uncut lumber that takes hours to process. You want to deliver the exact pre-assembled bricks.
That is a perfect analogy for supply chain logistics in biology. Essential amino acids are the specific amino acids that the human body cannot synthesize on its own. They must come from our diet.
Okay.
Products engineered specifically for human bioavailability, like the perfect amino profile mentioned by Gary Brecka, are formulated to bypass the digestive breakdown process. Because they're free-form amino acids, they're absorbed directly into the bloodstream in minutes.
And the utilization rate jumps from 20% to an incredible 99%.
Exactly. The body is getting the maximum possible payload of essential amino acids for tissue repair, with virtually zero nitrogenous waste.
There's also a metabolic angle to this that's fascinating, especially for people who practice intermittent fasting. A massive dose of these highly absorbable essential amino acids carries virtually zero caloric impact. We're talking about like 2 calories.
Which is critical for systemic recovery during a fasted state. Fasting triggers incredible metabolic benefits like autophagy, where the body cleans out damaged cells, and reduce systemic inflammation, both of which are highly beneficial for creating an environment where the nervous system can heal.
But the danger of intense exercise or daily stress while fasted is catabolism, right?
Yes, the body needs fuel, and if it doesn't have it, it will start breaking down its own lean muscle tissue to harvest amino acids.
Which defeats the purpose.
Exactly.
Yeah.
But by providing a 99% absorbable essential amino acid profile with negligible calories, you can completely preserve your lean muscle mass, supply the brain with the neurotransmitter precursors and structural proteins it needs for neuroplasticity, and maintain your fasted low inflammation state all at once.
To bring this back to the overarching theme, why does this deep dive into protein synthesis matter for the ringing in your ears?
It's all connected.
Because healing is holistically intertwined. You cannot expect a highly complex biological system like your auditory neural networks to recalibrate, respond to therapies like TMS, and repair damage if the body as a whole is structurally deficient.
Providing the body with highly absorbable, essential amino acid building blocks is about optimizing the physiological environment. You are giving the biological factory everything it needs to execute the blueprints for repair.
That makes total sense. Giving the body the structural building blocks is the foundation. It's the long game. But knowing that the brain is slowly rewiring itself doesn't help you sleep tonight.
Right, you need relief now.
We need to look at how we can interrupt that signal right now. What can you do right this second to manage the phantom symphony?
Managing tinnitus in the immediate term requires combining an understanding of the mechanisms with practical daily action. We're looking at 4 primary strategies: sound therapy, lifestyle modifications affecting the nervous system, photobiomodulation, and cognitive behavioral therapy.
Let's break down how each of these actually works at a physiological level, starting with sound therapy. We're talking about devices or apps that generate broad-spectrum white noise or nature sounds to mask the tinnitus. This feels like the most intuitive approach. If there's an annoying sound in the room, just turn on a fan to drown it out.
It is intuitive and highly effective for immediate relief. But the mechanism is actually deeper than just drowning it out. It relies on the concept of auditory distraction and sensory gating.
Sensory gating.
Yeah. Remember, the brain is hyper-focused on that phantom electrophysiological signal because it's the most prominent signal in the auditory pathway.
It has a monopoly on the brain's attention.
Exactly. By introducing a real, external, sound-like broad-spectrum white noise, which contains all audible frequencies, you're giving the auditory pathways a tangible external signal to process.
Oh.
It forces the brain to allocate processing power away from the internal static and toward the external acoustic environment. This can temporarily turn down the perceived volume of the tinnitus, allowing the nervous system to relax.
It provides that immediate temporary relief so someone can actually fall asleep or concentrate on their work.
Yes, exactly.
But we also have to look at how our daily habits are chemically exacerbating the neurological misfire. Lifestyle modifications. Specifically, looking at caffeine and stress.
This connects directly back to the vascular and neurological triggers we discussed earlier. Caffeine is a central nervous system stimulant. It does 2 things that are terrible for tinnitus. First, it acts as a vasoconstrictor. It physically narrows the blood vessels.
So if your tinnitus is vascular, driven by poor blood flow or turbulence, you're actively making the plumbing tighter and the turbulence worse.
Yes. And second, it increases neural excitability. It blocks adenosine, a neurotransmitter that promotes sleep and relaxation, leading to increased firing of neurons.
Which is bad if your neurons are already overactive.
Very bad. If your tinnitus is driven by hyperactive neurons in the auditory cortex, caffeine is chemically encouraging them to fire even faster and harder.
You're literally pouring biochemical gasoline on a neurological fire.
And chronic stress does the exact same thing through a different pathway. Stress activates the sympathetic nervous system, the fight-or-flight response.
Oh, right.
This spikes blood pressure, increases heart rate, and floods the brain with cortisol and adrenaline. This chronic state of hyperarousal puts the entire central nervous system on high alert, making the brain exquisitely sensitive to all sensory input, including the phantom tinnitus signal.
So you notice it even more.
Exactly. To heal, you have to consciously downregulate the nervous system through mindfulness, deep breathing, or meditation.
Speaking of downregulating and cellular healing, we really need to touch on photobiomodulation, specifically red light therapy. How does shining a red light on your head or body help with ringing ears?
It comes back to cellular energy. which we discussed regarding cardiovascular disease. Photobiomodulation utilizes specific wavelengths of red and near-infrared light, usually between 600 and 800 nanometers. These specific wavelengths are capable of penetrating the skin and even the skull to a certain depth.
And what are they doing once they get inside?
They interact directly with a light-sensitive enzyme in our mitochondria called cytochrome C oxidase. When this enzyme absorbs the light photons, it kicks the mitochondria into overdrive, prompting them to produce significantly more ATP, which is the energy currency of the cell.
So you're basically giving the cells a direct infusion of energy without them having to extract it from food or oxygen?
It's exactly. By boosting ATP production and simultaneously releasing mild reactive oxygen species that trigger cellular repair pathways, red light therapy helps reduce systemic neuroinflammation and provides the hair cells and neurons with the energy they desperately need to stabilize and heal.
Okay, so we've covered masking the sound, removing chemical stimulants, and boosting cellular energy. But the final management strategy is the one I find the most psychologically complex.
Cognitive behavioral therapy.
Yeah, CBT. CBT does not actually remove the acoustic stimulus. It does not lower the volume of the ringing. It is entirely about reframing your relationship with the sound.
This raises an important question, and it's often the absolute hardest hurdle for patients to overcome. How can psychological therapy help if the physical, neurological volume of the ringing remains exactly the same?
Wait, let me stop you there, because this is where I struggle. With CBT, you're telling me that the siren is still blaring in my head at the exact same volume, but you're saying I can just train myself to not care.
I know it sounds wild.
That sounds a lot like asking someone to sit in a burning room and ignore the fire alarm.
Your skepticism is completely valid, and it's exactly how most people react when they're first introduced to the concept of habituation. To understand why CBT is considered the gold standard for tinnitus management, we have to look at the limbic system, specifically the amygdala, which is the brain's emotional and fear processing center.
Okay, the brain's internal alarm system.
Right. Imagine you buy a house right next to a busy set of train tracks. The first week you live there, every time a freight train goes by at 3 a.m., it's deafening. It jolts you awake, your heart is pounding.
Sure.
Your amygdala flags that loud, sudden sound as a potential threat to your survival, and it triggers a massive fight-or-flight stress response.
Because evolutionary biology has taught us that loud, unexpected noises usually mean danger.
Exactly. But fast forward a year. You've lived in that house for 12 months. A freight train goes by at 3 a.m., and you don't even blink. You sleep right through it. The physical volume of the train has not changed by a single decibel. The acoustic stimulus hitting your eardrum is identical to the first night. So what changed?
Your brain learned that the train isn't a threat. It learned that a loud noise doesn't always equal danger.
Yes. Your brain successfully decoupled the sound of the train from the emotional response of fear. It categorized the stimulus as neutral, non-threatening background noise, and the amygdala stopped triggering the alarm. This process is called habituation.
Oh, wow. Okay, I see the connection now. With tinnitus, the core problem ruining someone's life isn't just the phantom sound itself. The profound suffering comes from the severe psychological distress the sound causes. Your brain is treating the internal ringing like a continuous, unresolvable threat.
Precisely. The distress creates a devastating, self-perpetuating feedback loop. You hear the phantom sound. Your amygdala perceives it as an intrusive threat. This causes severe anxiety.
And anxiety makes everything worse.
Yes. The anxiety spikes your stress hormones and increases the excitability of your central nervous system. Because your nervous system is hyper-aroused, it physically amplifies your perception of the tinnitus, making it appear louder and more intrusive, which in turn causes even more anxiety.
You're trapped in a permanent state of fight or flight over a sound your own brain is generating.
And CBT steps in to surgically break that loop. Through specific cognitive restructuring techniques, a patient learns to consciously reevaluate the sound. You use a prefrontal cortex, the logical part of the brain, to downregulate the amygdala.
Okay, so you're using logic to override fear.
Yes. You actively train your neural networks to uncouple the phantom noise from the emotional response of fear, frustration, or despair.
You're actively training your brain to treat the tinnitus like the train passing by the window. You hear it, it's there, but your body simply does not react to it. You neutralize the threat response.
Yes. You reach a point where the sound becomes background noise. You regain your peace of mind and your ability to concentrate, not by silencing the physical ringing, but by completely neutralizing its power over your emotional state.
That is so powerful.
It is. And this combination, The immediate physical relief of sound masking, the physiological optimization of diet and red light, and the profound psychological reframing of CBT can dramatically, tangibly improve a person's quality of life right now, today, while we wait for advanced neuromodulation therapies to become widely accessible.
That is an incredibly empowering perspective. We've taken quite a profound journey today, exploring everything from the physical fluid dynamics of the outer ear all the way deep into the synaptic plasticity of the brain's neural networks and finally into the psychological framework of human perception.
It's a huge topic.
It really is. So let's summarize the vital takeaways. What we've learned is that subjective tinnitus is a highly complex systemic interplay. It often originates with the mechanical breakdown damage to the delicate hair cells from noise, the biochemical toxicity of medications, or the metabolic starvation caused by cardiovascular disease.
Right, that's the trigger.
But it doesn't stay in the ear, it centralizes. The brain physically alters its own structural networks, turning up the central gain to create a phantom electrophysiological signal to fill the sensory void.
And truly grasping that neurological reality changes the entire paradigm of how we approach treatment. It shifts our focus from simply prescribing hearing aids to exploring cutting-edge interventions like transcranial magnetic stimulation, using the laws of physics to induce electrical changes and recalibrate those hyperactive brain networks.
That's the future.
It is. It also underscores the absolute, non-negotiable necessity of systemic health, demonstrating how providing our bodies with optimized, highly bioavailable essential amino acids creates the required biological foundation for any meaningful neuroplastic recovery to occur.
And most importantly, for anyone listening to this right now who is actively struggling with the sheer exhaustion of that phantom sound, there is a clear, actionable blueprint for immediate management.
There is hope, definitely.
Through the sensory gating of sound therapy, lifestyle modifications that reduce systemic inflammation and vasoconstriction, and the profound, life-altering psychological reframing offered by cognitive behavioral therapy, you can break the anxiety loop. You can reclaim your focus and your peace. The journey is incredibly personal, but the science is clear. You are not helpless, you are not alone, and our advancing understanding of neurobiology is bringing real, tangible hope. So what does this all mean for you?
Yeah, what's the takeaway for the listener?
It means it might be time to look deeply at your holistic health, evaluate the systemic stress you're putting on your nervous system, and actively engage in changing your relationship with the sensory inputs you experience every single day.
It truly is a paradigm shift in how we view the human body. And as we conclude our deep dive, it leaves us with an incredibly profound, almost unsettling philosophical question to ponder about the very nature of human reality.
Ooh, I love a good philosophical question. Lay it on us.
Think deeply about the core neurological mechanism of tinnitus we've just explored. Your brain is entirely capable of fundamentally restructuring its own synapses to invent a continuous, highly detailed, inescapably vivid symphony of phantom sounds, simply because a few microscopic sensory cells stop sending data.
Right, it just makes it up.
It completely fabricates an acoustic reality out of thin air to fill a void. So if our neural networks possess that level of immense creative power, the ability to seamlessly project an internal illusion so perfectly that we implicitly believe it exists in the physical world around us, what other physical realities are we experiencing right now that might also be neurological illusions?
Oh, wow.
What other chronic pains, what other intense physical sensations or deep-seated emotional perceptions is your brain actively constructing and projecting right this very second, based entirely on missing, faulty, or misinterpreted biological data?
That is a lot to think about.
The ultimate question tinnitus forces us to confront isn't just about what we hear. It's about whether we're ever truly experiencing the objective world exactly as it is, or if we're only ever experiencing a curated simulation, a reality that our constantly adapting neural networks are actively choosing to translate for us.